So today I'm presenting the topic is challenges of dealing bifurcation lesion in acute ST elevation MI. The prevalence of bifurcation carpet lesion in STEMI is approximately 10%. Only limited data is available on the preferred treatment strategy in STEMI patient with bifurcation lesions because STEMI patients have variable clinical presentation and that is also quite unpredictable. Common consensus and guidelines regarding the management of complex PCI, particularly bifurcation lesion, could not be made till now. Provisional approach should be on priority in context of this clinical profile. Regarding our case description, he was a 47-year-old male. He was hypertensive, non-diabetic, smoker. He had some pre-infarction angina class 2 since last 15 days and resting chest pain episode since last 2 hours when his ECG shows confirmed the diagnosis of ST elevation and T1 MI. Clinically, patient was in class 1 with no signs of heart failure or cardiac shock. Echo shows regional motion abnormality of proximal LAD territory without any mechanical complication, and ejection fraction was around 35%. Okay, right coronary artery injection shows diffuse plaquing in proximal part, and in mid RCA there is 99% disease segment followed by TIMI 1 flow. And distally, this PLV shows some biphasic flow, suggestion of some retrograde filling through left circulation. And ultimately, there are some grade 1 collaterals to this proximal LAD are visible. On LC injection, apparently left pin appears to be normal. LED shows diffuse plaquing in proximal part, and just after major diagonal, it was total thrombotic occlusion. And this diagonal one, that is huge diagonal, shows osteoproximal critical disease. Left circumflex flex also shows osteoproximal critical disease, and distal circ and one large OM is again filling retrogradely. So after looking this angio, first we think that it is a triple vessel disease. It is again a complex triple vessel disease because osteoproximal circ involvement is there. Right circulation is also not well maintained. So one option was to thrombolize the patient. But again, with this coronary anatomy, we did not give the option to thrombolysis the patient because we thought that if we restore the blood flow, TME3 flow immediately in this vessel, patient, it would be more better as compared to taking the risk of thrombolysis. So first we took XVU 3.57F catheter, and one wire was crossed in LAD and one in diagonal 1, and we did thrombus suction. And after thrombus suction, it was a serene and good integrate flow was achieved at the time. So after diagonal, there was diffuse disease segment involving a short segment of actitic segment also. Through this LAD and large diagonal, retrograde filling of this RC was also visible. In epicaudal view, this clearly showed that this diagonal as well as this mid LAD disease is quite tight. This is Bedina 111 classic bifurcation lesion, and there is this osteoproximal LCF disease also. So now one option was for immediate or urgent CABG. We discussed with the patient attendant, but they refused for CABG. So now we have to think about the PCI option in this patient. So now, what were the complexities till now in front of us regarding this angiographic profile of the patient? It was a triple vessel disease, and we have already seen this triple vessel disease was to that extent that RCA circulation was totally compromised. In mid RCA, it was TME 2 flow. Circumflex shows osteoproximal critical disease, and distal it was CTO, and the main culprit vessel shows bifurcation disease, and also involving this actitic disease segment. So this was complexities regarding the angiography of the patient, but the more complex situation we consider at the time that it was a case of acute ST elevation MI. So if we are planning for any PCI strategy in elective case, that we have multiple options, we can plan bifurcation strategy properly involving this for both left circumflex osteal as well as LAD diagonal. But in acute ST elevation MI, our plan was to minimize the procedure time, minimize the contrast load, and to achieve TME 3 flow without compromise of any average size vessel also, because in this patient had triple vessel disease with distal two CTOs, even a compromised blood flow compromise in a average size vessel will patient will end up with uh, it may be fatal to the patient. Patient might have hemodynamic collapse. So we plan first to do distal LED stenting. Distal means just from the distal margin of the ectasia. Then we decided to take imaging help of imaging. So we plan to take IVAS assessment of proximal LED. Proximal LED IVAS assessment regarding the extent of disease segment, regarding the bifurcation strategy and landing zone of the stent. So distal LED diluting stent 3 into 40 mm deployed at just distal to this ectasia at low pressures, and then we took IOS run. So IOS run shows in LED stent in proximal part, means distal to ectasia, size was around 3.5 mm. Although we did not do post dilatation, so MSA was not achieved and it was expected at the time. Our main purpose to do IOS in this segment was to just measure the size of this disease segment. And this was ectasia where size was MLA was around 20 mm square, minimum diameter around 4.8 from EM to EM. So we plan to exclude this segment from our next tent. It was ostial LED just at ostia, not coming towards POC. And there was significant plaque burden around 58.4%, and the vessel was size was around 4 m diameter. And in distal left main also there was plaquing. This was plaque burden was around 33%. One uh, thing was clear, that we are dealing with two bifurcation, not a single bifurcation. One was LED diagonal and other was left main bifurcation. But it was not possible to do complex PCI or double bifurcation in acute STEMI patients. And we have to decide the strategy for which we can achieve TIMI 3-4 with minimum time, minimum contrast load, and without any hemodynamic compromise. So as per latest landmark trial definition 2 trial that focus on these one stent and two stent strategy regarding the classification or categorization of bifurcation stent. So these are some 10 criteria for categorizing the bifurcation lesion into complex versus simple bifurcation lesion. So for us, challenging aspect were it was double bifurcation, and definitely so LED diagonal bifurcation, it was complex lesion because one major criteria of side branch lesion more than 90%, more than 10 mm disease was there, and minor criteria of thrombotic occlusion of main vessel disease segment more than 25 mm was there. So it was a complex lesion. So as per ideally two stent strategy should be there. But this and for LMC bifurcation, it major criteria was there. Although we did not do IVAS of left circumflex, so one minor criteria of calcification we cannot comment of that, but still it was only one minor criteria was there. So we planned for provisional strategy in LMC bifurcation. But again, for provisional bifurcation, whether we have to wire the left circumflex, because 3-wire handling of 3-wire wicks with aux balloons in our settings, it will be a difficult task, and it may increase the procedure time also. So definitely it was a challenge for LED stent proximal landing zone, whether we have to go for crossover strategy for LMCA to LED, or just ostial LED placement is sufficient. So we planned that we will do dedicated two strands bifurcation in LED diagonal, and the proximal and LED stand will place at just at ostia. So we first did pre-dilatation of diagonal with 2.5 into 12 mm MC balloon, and diagonal stand was done with 2.75 into 28 mm with just 2 mm protrusion in main vessel. And after that, we deploy this wire from diagonal was removed, and LED stand 4 into 28 mm was deployed. After it, we did first pod with 4.5 into 8 mm balloon. because it was in ectatic segment, and I was shows that at ectatic segment we can post directly with 4.5 mm balloon also. Then recrossing of this diagonal done through proximal studs, and post dilatation of LED done distally and mid part to 3 into 12 mm balloon, and in proximal part with 3.5 into 12 mm balloon. After that, we did kissing with 2.75 into 12 mm balloon in diagonal 1, and 3.5 into 12 mm balloon in LED. And the second part with 4.5 into 8 mm balloon with precaution to maintain this new carina was done. And in caudal view also, this ostial, this proximal margin of the stand was post directed with this 4.5 mm balloon. After that, we took the IOS one. So distal LED stand in proximal part after this activity segment that we have seen in previous view. Now MSA of 11.7 mm square is achieved. In LED diagonal, you see new corona, good new corona formation is there. Both strands are well posed, and there is no strand deformation or stress deformation is there. This ostial LED stand was IVAS frame was taken just at ostial LED before coming towards POC, and 12.6 mm square of MSA is achieved here. And from that point to this point, this POC figure of 8 is well maintained, no pinching of left circumflex, and it was the last IVAS frame where stand studs of LED could be visualized, and it was 1.3 mm distal proximal from the actual from this actual ostial LED side. So there is hardly 1.3 to 1.4 mm protrusion of studs in left main. So this was final epicaudal view. There was no compromise of left circumflex. Cranial view also acted as well tackled. Good anti-gate TME3 flow is achieved. So take-home message is PCI in acute STEMI is a clinical complexity itself. So lesion complexity makes the situation terrible for operator. Target should be to achieve early revascularization with TME3 flow. Try to choose least complex approach, whether it is bifurcation or whether it is other complex PCI. Sometimes there may be different approaches for the same case, but ultimately primary operator is the best judge who is dealing with the patient hemodynamics, patient symptoms, their transient hemodynamic compromise that cannot be discussed or shown in this webinar. So for bifurcation lesion, always consider for provisional approach if feasible, and your decision will decide the short term as well as the long term outcome of the patient. So ultimately, with favorable hemodynamics, with TME3 flow, without any complication, to shift the patient of myocardial infarction from cath lab is the dream and should be the approach for every intervention cardiologist. Thank you.
Thanks, Naresh. It was a laborious case, long one, and you did remarkably well by doing a very good bifurcation stenting of LED diagonal, where other vessels were also involved. And I agree with you. Once we're dealing with acute MI with a lot of bifurcation situations like this, it's going to be very tricky. So let's involve Kunal. Kunal, your viewpoint.
So that was a wonderfully presented and a wonderful execution of the whatever he discussed in the case. The only Dr. Naresh, did you consider using IBP because there were a lot of
definitely that's other important issue. Because in clinical history also I have shown that patient has some pre-infarction angina, and that was the benefit of the patient at time of this 2 hours of chest pain with this angiographic profile. Patient was still not in cardiac shock. His BP was 130/80. So we planned, if we will go for left main to LED stenting, we will go for IBP. But if not, so our plan was changed. So we did not consider for IBP because patient was not on inotrope support at the time.
The only thing which I just could add to the case was you could have kept a wire while you were placing the osteal LED stent. Ideally,
Sir,
because osteosuck was critically diseased, it would have been better if we could have kept a wire in LCX.
yeah, definitely, sir. This I also told regarding the third wire that we are using this aux hardware at the time. So placing a third wire, and if our we have faced a difficulty regarding crossing this aux balloon in LED diagonal bifurcation, and our main purpose of doing the early restoration of blood flow is delayed. So that's why we did not keep the third wire. Otherwise, it was a planning to whether to keep wire or not in LCF. Although ideally should keep, but if you are taking new hardware, so definitely should.
What are you planning for the osteal L6 lesion in future now in this patient?
Sir, in osteal L6 lesion, first thing whether we should plan for CVG or PCI in this patient, it is an important decision. So if we go for PCI just for academic discussion, there is 1.3, 1.4 mm protrusion of left of LED stent in LCF. So one approach is that we can make it reverse crush. We can crush this LED stent and do so a left main to LCX stenting. Or one option is there that we can put another stent from left main to LED and do then do this stenting of circumflex. Whether DK crush or keloid, it is operator choice.
So what will be your opinion in this regard, sir? What should be done with the osteal L6 lesion? Because we are not sure whether it has protruded into the left main or we have just missed the LED ostium. Although he showed some struts just at the level of PUC, but we cannot be 100% sure whether. So, sir, what should be done? Is a drug-eluting balloon more helpful in such a scenario, or we should go ahead with stenting if patient has angina in future?
Yeah, I think so. So circ also is a big vessel. So rightly so, whenever such like tricky situations arise in acute ST elevation MIs, then firstly I think we should restrict ourselves to deal with the culprit lesions only if the patient is not hemodynamically unstable. If the patient is hemodynamically unstable, then it's a different ball game altogether. But as Naresh also mentioned, the blood pressures were relatively fine in this patient. So then we deal with only LED. Somewhere I believe, here also dilating the diagonal and keeping it provisional was also one possibility. So in ST elevation MIs, let's not try to try to achieve perfections. So it's a very tricky situation. The hormonal surges are very high. Prothrombotic chances, the stent thrombosis rates are also high. So if it is absolutely a dual LED situation and a very big diagonal giving reaching the apex, again it's a different situation. But here this is my viewpoint. But finally, Naresh has managed it quite well with all the TIMI3 flows and very good kissing balloons. Now, if we are coming to circumflex, and if our stent was protruding into the left main, yes, it could have been a kissing balloon at least with a drug-eluting balloon, if possible, at the circumflex ostium, and rest to deal with later on. And also now RC is also disease, Naresh, in this.
Yes, sir. RCA, mid RCA around 99%, then TIMI 1 flow. And
So
digital PLV is.
if you take my advice, just fix the RC in the next sitting and then get a stress thallium after 2 months. What to do with circ based on the ischemic zone, how much ischemic zone is there, and based on that take a call. So how to deal with left main bifurcation, that's totally a different viewpoint. We can keep discussing that. But overall, it's a very good case, Naresh. Thank you.
Thank you, sir.